Dr. Komal is not there, so we have 4 panelists. We'll have questions will be distributed among these 4 panelists.
Sure.
So we have a good. Can I have one more chair, please?
Yes, yes.
And
Please arrange. Please arrange.
we can have chairs so that the screen is seen. So before I start off, I'll again go for some audience interaction, and I'll have audience questions and audience interaction. We will have a free-flowing session. We don't want just a lecture going on and then people listening and going away. So we'll be discussing some questions here. There will be questions for academics purpose, like you what we read in a book, like types of diet and glycemic index. These are questions, but they are questions which you don't read in a book. That is, what do you give to a patient who has metabolic syndrome with obesity? So if a patient comes to you who is obese and asks you what should I eat, so we have to answer those questions. We cannot just go to a book and see. Then we have questions like what to give a metabolic syndrome who is not fat. Obviously, he can be fat outside, a fat inside, but he is not obviously fat. What we call as TOFI. It's a famous term used in our fatty liver, thin outside, fat inside. Then we use. So we have these questions, and we will be discussing these questions. Can I have Dr. Komal's slides, please, now? No, Dr. Komal was, unfortunately, is not able to come. So just a second, just after this slide. So before we go to Dr. Komal's slide, we'll have a question on what do you assess in a patient in metabolic syndrome. I have some queries. So Dr. Parag, please. So he has a lot of interest in plasma insulin levels. So I want to talk. He may not be a panelist, but I want you to discuss something about plasma insulin levels. Can I have the? No. We have others also will be answering the question. Parag is not one of them.
See, essentially, uh, the most common mistake that we all do, see, we all have been knowing and screening our patients for fatty liver. We all see 2 to 3 patients weekly in OPD, 60, 65 years who come with cirrhosis, who are actually who have no viral markers which are positive. They don't even taken alcohol, but nobody had asked them to screen themselves for fatty liver. We don't have the facility for the liver elastography MR liver in Baroda, so we use fibroscan. So what I have been doing since last 2-3 years for my own academic interest is, because we as a physicians get a lot of people with hypercholesterolemia, so I used to get their fibroscans done. And those fibroscans with LSM of 8, 9, 10 are extremely common. So when we correlate them with the plasma insulin levels and the HOMA IR2, we get something very fascinating. Now, thin people with significant higher insulin levels, commonly I get in Toprani's lab. So Toprani levels are in Baroda, it's up to 24, but they have the wrong values.
So I just want to stress on this, the plasma insulin levels which you are getting in the labs are all wrong.
Yeah.
Okay, the 24 level which is mentioned in the lab is wrong. So please, Parag, can you tell me what should be the proper levels which the physician should see?
Yeah, we should target 6. If your levels are less than 6, you are good. If you are more than 7, then your chances of insulin resistance is significantly more. Even if your levels of HOMA IR2, even if it is less than 2, but then your insulin levels have to be less than 6. The moment your levels pass more than 7, you are likely to develop hyperglycemia because of the Indian issues of visceral fat and all things that we know. So if somebody asks you, what's the first thing that you need to do for patients? Somebody asks you, I don't know, my fasting sugar is 90, I don't have diabetes. Please get your fasting insulin level and HOMA IR2. Because fasting insulin level is the first thing which we are missing in our practice. So we must implement that on a regular basis. In fact, in the screening test, somebody, if I am to make a policy maker, I would ask that all these hospitals, big hospitals, they make that corporate checkups. They must include 2 things. One is the fibroscan, and second is the plasma insulin HOMA IR. These are compulsory things. Because we find, yesterday's OPD, I picked up 3 fibroscans with LSM of 11.2. You will thin lean people. How would I suspect? Just on the basis of plasma insulin was more and the HOMA IR.
So this is, thank you Parag for
something
the
very important.
Secondly, I was stressing on this lipid profiles. Yes, madam, please. I think we'll take that discussion afterwards. We'll just concentrating on the second, because we are dealing with metabolic syndrome and on the lipid profiles. Now we all look at LDL levels. So we can have someone else to answer this question. Dr. Akash, you can answer about what do you look for in lipid profile? You look for triglycerides regularly, or you look for HDL levels regularly? What else you look for in this? In this, and then Samir can take up this question because you are dealing with lipids.
So HDL levels are marker of future cardiovascular risk. The modification of HDL by any medicines does not make a difference in the prognosis of the patient. So by and large, HDL levels are marker of future disease.
So when we look at LDL levels, we do we have facilities for finding small dense LDL versus?
See, there is something called as advanced lipid panel, which is sparingly done even in US. It is not available in India.
Can we indirectly measure the small dense LDL by the lipid profiles which we see?
So there is something called as diabetic dyslipidemia, where you have more of triglycerides and LDL maybe
Samir, you want to take up this question?
Slightly above. So here basically there are more chances of small dense LDL, there are more chances of oxidized LDL, more chances of glycosylated LDL. So basically this is what happens. So indirectly you can know that patient is having dysfunctional LDL which is more atherogenic.
Samir, you would like to answer?
So, I would like to add one thing to what Parag said. I've been using all these tests that you mentioned here, plasma insulin C-peptide, for my bariatric patients since 2010. And the fasting level we target is because our group of patients are very metabolically ill. We target less than 10, right? Not 6. We target less than 10. And LDL. So LDL, there are two tests.
Just I want to answer on this question. We don't have the facilities for small dense LCL in Baroda. Do you have any reports available with you?
Yes, ApoB. ApoB.
ApoB is one of them.
ApoB is the single most important marker in your blood report, lipid profile, which can predict the risk of heart disease.
I would again stress something different. Sir. Yes, that is the answer. Sir, 2. I think, sir, that's the reverse. If you have the ratio is less than 2, you have a normal small length LDL. As the ratio rises more than 2, so if your triglycerides are 120 and HDL is 50, the ratio comes as 2.4. Your LDL is more likely to be small dense LDL. So the easiest test in lipid profile, where you, even because you don't have the measurement of small dense LDL, is to look at the triglycerides to HDL ratio. If your HDL ratio is 1 is the ideal ratio. Okay, 1 is the ideal ratio. HDL to triglycerides 1 is the ideal ratio. 2 is acceptable. Beyond 2, you are going into a higher small dense LDL.
So A to ApoB ratio is a very accurate predictor of the risk of heart disease.
Now, madam, please, Manisha madam, we talked about anthropometric measurements. We have BMIs and we have waist measurements. So what do you believe should be the ideal way of measuring a person's metabolic health? Should it be the BMI? Should it be the waist measurement? What should be because we all measure BMI and we say it's obese. I find BMI is useless. Okay, so what do you comment on that?
Absolutely true. BMI is not useless, but it's a first step for anthropometric measurements. We need to do the waist and the hip circumference. The waist to hip ratio is definitely a predictor. For females, more than 80. If a person is having a patli kamar, that is what is the ideal. We also have conicity index, where without any invasive parameters, with the weight, height and waist circumference, you can predict metabolic syndrome. And if you can purchase a Tanita body composition analyzer and assess your fat content, your metabolic age versus your actual age is also predicted and seen in that. It's not very expensive, just 3,000 rupees. So I think all physicians should have a body composition analyzer machine in their hospital setup, and that will help you to
actually DEXA scan is the best method, but usually waist circumference.
Ma'am has something to add.
Yes, madam, please.
Just a quick point. There's this concept called normal weight obesity, which I believe we're going to discuss later.
We'll be discussing.
And
just measurement.
The point is, waist measurement is a fairly good substitute to for the body fat. So rather than measuring the body fat, that's not available.
Still, I believe the waist measurement should be half of your height, less than half. So you have a height of 66 inches. that is 5 feet 6 inches, your waist circumference should be less than 33 inches. As it crosses 33 inches, you are going to visceral obesity. So we have questions. Now we have Dr. Komal who was going to answer these questions. Dr. Komal unfortunately is not here. So we'll have the other panelists taking up this question. Dr. Sunita, Dr. Komal has requested you to take up. So can we discuss something about the types of diet? We will be focusing this. We have different types of diets available with us. Can you take up something?
I think she's shared a presentation.
So we can have Dr. Komal's presentation, please. Meanwhile, you can elaborate on.
Okay, so shall I come there?
You can stand there, you can sit there, or always are convenient to you.
Okay. If we
See on this, it will be
Yeah.
coming here.
Fine, fine. Maybe I can, sit here. Fine. So, since this is a presentation prepared by Dr. Komal Chauhan, and I think it was essentially on addressing the issue of how about a low-carb diet, a very low-carb diet, and can we just have the
Next, please.
Yeah.
Next, please. You can be fast.
I'll just quickly go through it. So, essentially, this slide talks about the fad diets that are taking over. The keto diet became very, very popular in between, and a lot of people were essentially switching over to a keto diet. So, the ketogenic diet, which is essentially very low in carbs, generally has high protein sources like nuts and high dairy fat and others, which is very similar to the Atkins diet is prescribed under keto diet. Now this diet leads to massive reduction in blood sugar levels, causes ketosis, which is not unhealthy, which is not dangerous, and it also has numerous health benefits like weight loss. In the long run, it can create a lot of problems. I have had people walking in, especially young boys, who switched over to a ketogenic diet, and when the exams came close, there was this fogging of brain because of low carb diet. So it's not prescribed in that case. Some of the versions that are available are the standard ketogenic diet, which has 75% fat, 20% protein, and 5% carbs. Cyclic ketogenic, the diet revolves between higher carb and low carbs. And then there is a targeted ketogenic diet, which allows to add the carbs around workouts. Then high protein ketogenic diet is also prescribed, where the ratio of fat is around 60, protein 35, and 5% carbs. However, only standard and high protein ketogenic diets have been studied extensively, and cyclical methods work best. So in these diets, essentially, the foods prohibited are the sugary foods, grains or starches, fruits, beans or legumes need to be included. Essentially, some of the beans and legumes are very high, especially the peas are high in carbs relatively than protein. Root vegetables totally omitted. Condiments and spices, which are generally rich in carbs and sugars. And alcohol, which is again, not allowed. Sorry. And sugar-free diet foods are allowed.
I think we'll stop here. We'll just take up few questions from the house. Anyone has queries on the ketogenic diet? Because I think that is the most, we can have the panelists to answer. But anyone has queries on the ketogenic diet? So, Samir, you can answer. You want to tell something?
Just to clarify, there is some error. Ketogenic diet is basically low carb, high fat. Right? That is the distinguishing feature between a very low carb and the ketogenic diet. Very low carb diets will have a reasonable amount of protein, but in ketogenic specifically, it's higher fat content.
Basically, ketogenic diet means basically eliminate the carbs and the person is not using, is moving only fatty acids.
And replace with fats.
Replace with fat. So we have something like ketogenic diet. We have paleo diet also. We won't be talking, that is only eating foods which are raw and used to be eaten thousands of years back. So Dr. Vanisha, we have these diets now. You feel that we can have diet to be used in reversal of diabetes? We're not talking about drugs. Diet.
So the question is, can diet reverse diabetes?
Yes.
If there
And
are
which diet?
It's a newly detected diabetic patient, less than 10 years, yes. You can definitely take care of your HbA1c. within 3 months, if you follow a very low calorie diet, we have evidence, 800 kilocalories, carbs less than 50, you can definitely reverse, we have evidence on that. However, sustainability is a big issue. Social behavior change communications is needed. The patient who is on a very low calorie diet has to be constantly monitored. They may be at risk of severe and micronutrient malnutrition, which has to be given. For a person who is following a severely low carb, very low calorie diet, you need to supervise him very closely and also put him on formulas at least twice a day so that his micronutrient malnutrition is taken care of.
Now I want to talk
But to sustain this, you need to then gradually switch over to low calorie diets and then to a balanced diet with a lot of functional foods which can take care of your glycemic index and glycemic load reduction.
You
Thank
feel it is possible to do this?
For a newly detected diabetic
Less
and
than
a
10 years.
diabetic who is having a history of less than 10 years. Yes.
We have Dr. Manjusha here. Dr. Manjusha, I would like to ask you this question. Have we, as physicians, used diets in the reversal of diabetes? Or all this is theoretical? Can I have the mic to the, please, mic to her.
Can somebody give mic?
Please the mic. There is a mic here, madam. You can come here.
Yeah, there is a mic there.
So we have seen a reversal of diabetes. That's why my practical point was, mine is not on. Now it's on. So we have been able to stop medicines and you may not have been to give medicines. So that has happened. So it's not a myth, it's a reality. Anyone wants to answer this? It's not is it a myth or is it a reality?
So there is reversal, there is remission, and that happens when it is either pre-diabetic or a newly detected diabetic. So when you have too many comorbidities already set in, it is difficult. But insulin resistance is something which can be taken care of with diet and exercise.
Okay, Akash, you. Yes, please, sir.
Showing that now we are getting only around 5% reversal. Till now the studies are showing only 5% in newly detected to diabetes. And last year they have come out with the guidelines for remission and reversal. They are telling that if this remission is maintained for minimum 3 years at a stretch, then only you can mark it as a reversal of diabetes. Otherwise not.
So
There
it's
have
a
been guidelines
valid-
recently for partial reversal, temporary reversal. There have been some classifications also. And the latest one says that only if it's maintained for 3 years, then only you can think for reversal. And till now the studies are showing that it's only 5% cases that you can go for
So
reversal.
we should always attempt. So there is a reality to it. We'll come on to the because we don't want to continue on the same. We have Dr. Sunita here. She has prepared a nice PPTs on the glycemic index and the glycemic loads and what is the better of those two. Dr. Sunita, please.
Okay, thank you so much. So I think the audience here very well knows what is glycemic index. I don't need to, go into the details of that, but it is just a way of classifying or ranking foods according to their potential to raise blood glucose levels. And it's recommended that generally foods that have at least 15 to 20 grams of available carbohydrate, that is the starch that can be digested, which is the alpha and not the beta linkage, should be assessed on GI. The formula is, as we know, incremental blood glucose area of 50 gram of test carbohydrate upon the same of reference food. On the other hand, glycemic load makes use of GI in its equation, if you can see, and multiplies the GI by net gram of the carbohydrate present. So, as per the formula, it suggests that as you increase the amount of carbohydrate or the amount of food that you consume, GI remaining the same, the glycemic load increases. And a simple example that is quoted every time is spaghetti has a lower GI than boiled potatoes, but under normal conditions, the portion size that we consume of spaghetti is much higher, and therefore it turns out to be worse than the potato. These are the cutoffs we are all familiar with for the glycemic index as well as the glycemic load. Next one, please. So, which is better? The glycemic index, since it tells us only about what food increases blood glucose, but fails to describe how much food should we take at a particular time. Therefore, it is not a perfect system, but a helpful tool. But the glycemic load takes into consideration the amount of carbs or the food that is being consumed. Hence, glycemic load appears to be beneficial in dietary programs, especially targeting metabolic syndrome, insulin resistance, etc. A word of caution, just because a food is low in GI doesn't necessarily make it a good food. Certain foods that give low GI are essentially low GI because they have high amount of protein and fat. And therefore, we have to be very careful with such foods. Next, please. This is just a simple way of showing how increasing the quantity keeps the GI same but increases the glycemic load, and ultimately it is the glycemic load that should be considered, and I have put some values. Next, please. So these are from Indian studies conducted on Indian foods, and the value for apple, the GI is 36, serving size is 120, glycemic load is 5. So we really need to give this kind of a chart to our patients when they come to us, or the subjects when they come to us. The values are average of at least 5 to 6 different varieties. It's not just one single apple that has been analyzed. Similarly for banana, the cherries, the serving size matters, right? And so the pear, the pineapple, papaya ripe, in fact, has a very high GI comparatively. Dates are considered to be, very healthy, but not all varieties, the medjool dates, do have a very high GI, medium to high GI. Can we have the next one? Yes. So we do not consume raw foods. A lot of data is available on raw foods. I preferred to select this data on GI and GL of cooked foods, and then we don't eat a single food. The problem is we don't have the data for GI and GL of composite diets, but whatever we have available is shown here. If we have chapati along with green gram dal, the moong dal, we can see for a portion size, serving size of 200, that is 1 katori of dal and 1 thin roti, the glycemic load will be 41. Chila has a relatively low glycemic load, both Bengal grams, so it's essentially made from dals and therefore has a very low GI and GL. Dosa, idli, if eaten along with a chutney, it needs a cover. The carbohydrates always need a cover of protein or fat in order to lower their GI and GL. The boiled rice, white rice, doesn't have that higher glycemic load. The khichdi, if we add vegetables and dal in the right proportion, so what we advise generally is, instead of making khichdi with the ratio 3:1 for rice and dal, make it 1:1, and it will definitely bring down the GI and GL.
I think this is a very important slide, and we should all know, because the food which we eat, glycemic load is more important than glycemic index. Because some foods are eaten more amounts, and that is what ultimately is the sugar. It's not if you eat a small amount of something, you can have a high glycemic index but no poor glycemic load. Okay, so we come to this next
I
session.
also had something on the second meal
because
effect.
we are running short of time, so
Fine,
we'll come
fine.
to that.
No
So
problem.
we have Dr.
Thanks.
Smita here, who will be talking about carb counting. We have a question on carb counting, we like to her to discuss.
Okay, so carb counting basically is most crucial for a patient with type 1 diabetes. How does it help in type 2? At least you maintain some consistency in the amount of carbs that you consume per day. More important, there's a kind of limit which you do not cross. Now, what is a convenient way to count carbs? There are so many ways, like most important, or let's say most important abroad, is reading labels. You see the serving size, you see the total carbohydrate content. Not many of our patients, the major diet is not only things in cans. So what can you do? You can use exchanges, you can use a nutritionist or a dietitian who would advise you. What I find convenient, dear friends, is 2 apps. And I would strongly encourage that we all use them, because only when we are conversant with them can we advise our patients to use them. The one that I use is called MyFitnessPal. Many of my colleagues use Healthify. Healthify, I believe they're comparable. I'm just more comfortable with MyFitnessPal because you can count the macronutrients, basically. Now, is this an ideal solution? Just by counting carbs, and suppose you have achieved a low-carb diet, are you happy? Not really. There are quite a few disadvantages to this. For example, I would like to ask you, dear friends, can you think of a food, and I put that in inverted commas, can you think of something which is extremely low carb but extremely unhealthy? Anything.
Anyone from the audience? Please.
Anyone from the audience. I would call it poisonous.
Low carb but extremely unhealthy.
Oils are not too bad all the time, sir. You mentioned that they're not so bad in your talk. Okay, maybe, but something even more poisonous. I don't know, I mean, it's something that our teens drink all the time. Teens? Coke, Diet Coke. Diet Coke. I'm not even going to say Coke, I'm going to say Diet Coke. Right? Yeah. So just counting the carbs is not really enough. Another disadvantage of counting carbs is this. The patient is not just eating carbs. He's also eating protein and fats. And what these protein and fats do is they influence the rate of absorption of the carbs. So you don't know what level of sugar is being absorbed. So counting carbs, I would think it is part of diet management, but definitely it is not sufficient. A word about complex versus simple, something we all know. Now, complex carbs basically take longer to get absorbed, and they result in a relatively stable blood sugar level. But what fascinates me much more about complex carbs is where are they present? They are present in high fiber foods. And what high fiber foods do, what do they do, friends? What do they do that decreases almost all cardiovascular risk? What do they do? Okay.
Anyone else?
Anyone in the audience, what do they do to something in the
Yes,
intestine? Yeah?
Huh?
Absolutely. Okay, but madam said something. Madam was saying gut microbiota.
Yes, gut
Okay?
microbiota.
Gut microbiota. These influence almost every single aspect of cardiometabolic risk. And so when you consume complex carbs, of course, the rate of absorption, everything, so all very good. But the major way I feel, and what the evidence says is, they influence favorably the composition of the gut microbiota.
I think that's a very important thing, the gut microbiota. We have the short chain
Also, the
fatty
addition
acids.
of short chain fatty acids.
Yes, short chain fatty acids. So that's an interesting thing. So now we come to clinical cases. Dr. Samir will take up the first case. So if you have a patient in your OPD who has come with metabolic syndrome and obesity, and he doesn't have diabetes, blood pressure, anything else, he's 25 years old, he's obese, and he's obese here we define as by BMI, 25 and more. So Dr. Samir, whether you will intervene, I'd like you to answer these questions.
So if he's just overweight, not obese, like obese means it's more than 27.5 BMI. So obesity, so overweight, the treatment is different. Type 1 obesity, type 2 and 3 will have a different approach, of course. But if there is no metabolic syndrome,
He has metabolic syndrome.
He has metabolic syndrome, but no comorbidity, so no diagnosed,
hypertension,
no diagnosed,
no dyslipidemias.
Yes. So,
But you intervene, that's what I'm telling you.
Yes, definitely.
So just before we come to this question, do you have something like healthy obesity? Anyone from the audience knows what is healthy obesity? First we'll take up the audience. Anyone from the audience tells something like healthy obesity? You can have a weight, BMI more, but still you're healthy. And we have many people. We have people living till 80s and you're obese and they're healthy. And we have, Akash please. So why should the fat not be inflammatory? No, it's because it's not visceral. The fat which is inflammatory is visceral. So fat which is sub-Q is not visceral. So what has happened in Indians? Why Indians have more this unhealthy obesity? Because we have less sub-Q space. We have been born in a very warm climate. We don't require sub-Q fat. The Europeans require sub-Q fat as an insulation. We don't require sub-Q fat. Our genetics is visceral fat. So when we get, the sub-Q compartment is less. So when we get little bit of extra fat, it goes to the liver or the pancreas. So those people who have obese but less visceral fat, they are healthy obese. So they may be BMI of 27, 28.
And morphologically, there are two types of obesity.
Yes,
One
yes.
is hyperplastic, another is hypertrophic.
Yes, yes.
So the hypertrophic will be metabolically active, and that is the one which is dangerous. So the Asian population is prone to more of hypertrophic, where the hypertrophy of the adipose tissue will increase, but there is no simultaneous angiogenesis leading to hypoxia of the adipose cells. That leads to inflammatory marker release, and that leads to metabolic
What
syndrome.
happens, one more thing is hypertrophy is the number of cells or the larger cell.
Larger
A larger
cell.
cell is harmful, a number of cells.
Number of cell increase, it will give you a metabolically inactive obesity.
Yes, yes. So,
Right? So, metabolically healthy.
You have metabolically healthy obesity. So that's why I'm asking the question whether you should intervene or not. So all obese patients, you may not intervene. If you feel that the visceral fat is not there, they can live their own life. Okay, you can ask them for a shape purpose or for...
They will have mechanical issues, but
That is it.
no metabolic
so what
issues.
investigations we already covered? What sort of dietary interventions would you advise in these patients?
So if the patient is obese and or overweight and there is metabolic syndrome, definitely we have to measure the insulin level and the C-peptide levels, the HOMA-IR, and uric acid, whether patient has triglycerides increase, though they might not be very high, but there is some indication that the ApoB is slightly on the higher side. So he is going towards full-blown metabolic syndrome. These patients, basically metabolic syndrome, the clinical definition is carbohydrate intolerance syndrome. So the treatment is reducing carbs, especially refined carbs. That is the only treatment. There's no other dietary advice that you can give to patients with metabolic syndrome.
I'll just touch upon this fasting thing. Now we'll have fasting later also. Would you advise these patients for intermittent fasting or 5-2 fasting?
Yes, I think intermittent fasting should be done by a normal healthy person also, metabolically unhealthy person also, and especially obesity with metabolic syndrome. The intermittent fasting is going to play a major role.
Okay, we'll come, rest of the questions also will cover. Dr. Sunita here. Now we have a patient who is BMI is normal, but he is metabolic syndrome, which is common in India. We have high triglycerides, the waist circumference may be high, but his BMI is, so how do you manage these patients? They are not diseased, okay? There are patients who are having dyslipidemia, triglycerides, but normal BMI. So what would you intervene in this group of patients, or any difference from Dr. Dr.
Yeah, can I have the
Samir has told?
presentation? Can I have my presentation?
You can have, yes, presentation.
Yeah, so we are essentially talking about the normal BMI, that is metabolically obese normal weight or normal weight obese people. Next, please. So yes, why should we intervene? So if this illustration very clearly shows the middle one, you know, those who are normal weight normal weight obese, they are more likely to become diabetic sooner than the other ones. So next one. So we need to intervene. How do we intervene? This syndrome is characterized by high body fat percent, and therefore, though they present with normal body weight, they have insulin resistance. Next, please. So BMI, since it does not distinguish between the lean body mass and the fat mass, we have to do the body composition analysis. A very simple way of looking at, the simple handheld body composition analyzer will do. DEXA is the gold standard, but expensive as well as time consuming. Alternately, we can assess abdominal obesity, and in my experience, I have found that waist-hip circumference doesn't work out so well for the short, fat Asian phenotype, but it is the waist-height ratio that works out better. Look at their physical activity using GPAC, that is Global Physical Activity Questionnaire, because these people, because they have normal weight, they think they don't need to exercise. Most of them are sedentary. The dietary intake based on 24-hour dietary recall, 3-day multiple pass method, because these people tend to follow a good diet and binge during the weekends, and therefore the whole problem. Look at their snack and beverage consumption, frequency of fruit consumption, assess the frequency of eating out, analyze dietary data for sources and quantity of carbohydrates. The quality of carbohydrate, fat and protein is very important, and assess the chrononutrition profile. All the studies that we have done, these lean people, they have insulin resistance, they have, their chronobiology is totally disturbed. And when we talk of chrononutrition, somewhere fixing the eating window comes in, so intermittent fasting also comes in. Indian diets are usually high in carbohydrates, so what we need to do is fix the calories that come from carbohydrate, proteins and fat. No more than 55% of the total calories coming from carbohydrates, less than 5% from sugars. These are the latest dietary guidelines for Indians given by NIN. Good quality protein, the good healthy fat which is rich in MUFA, not so much in PUFA and SAFA, judicious food combinations, combining wheats and millets. Oats are considered to be very healthy, but to tell you, except for steel cut or rolled oats, other oats have medium to high GI. Always combine cereals and pulses, make a combination of cereals and vegetables, and so on. Can we just go back to the previous slide, sir, just for a moment? No, the table, yeah. So this is some data from our research that we have done on processed packaged foods, and where do some of the sugar, hidden fat, hidden sodium come from most of the packaged foods. These are some of the, I have data on some 500 foods that we have analyzed in our labs, and you can see the wafers, chips, extruded snacks may contain sugar, maltodextrin, corn syrup. The high fructose corn syrup is the biggest culprit we know, and the chocolate candies, jellies may have it. Of course, the sweets would have it, but it will have multiple sources of sugars. That is the problem. The salty biscuit, I have purposely named Maska Chaska, because that is one where we least expect sugar to be there, but it has maltodextrin, liquid glucose, invert sugar syrup, some of the breakfast cereals, the sweet spreads like the peanut spread, etc., the sauces, ketchups, chutneys. Many of these foods also have hidden sources of sodium in the form of MSG, the leavening agents, etc. So we have to be very, very careful with all these.
Thank you, thank you.
Thanks.
Now, Dr. Vanisha, we have now a patient with metabolic syndrome with obesity who has now started to have the complications of that metabolic syndrome. He has diabetes, dyslipidemia. Is there a difference between the diet Dr. Samir has told and Dr. Sunita has told? Any difference would you feel, or you elaborate on your own? What do you feel?
So
what additions would you make?
Dietary guidelines for patient with diabetes and dyslipidemia remains basically the same because the person is having metabolic syndrome. So either of the 5 would be there for the patient. He would be having a high waist circumference, or BMI is high, or blood pressure, or diabetes and dyslipidemia is already mentioned. So you need to work on reduction of insulin. You need to work on the carbs first, because insulin resistance is the mother of all diseases, whether it's dyslipidemia or whether it's the blood pressure. So control your carbs is number 1. Increase good quality of carbohydrates with lot of fiber, at least 30 to 40 grams of fiber. That to increase your soluble fiber intake, and that will help you in control your diabetes. Okay. As far as control of dyslipidemia is concerned, good quality of fat. You need to have your seeds, you need to have your grains, whole grains and cereals, ultra-processed foods, which is a strict no-no for
we have some
patients.
common things, ultra-processed foods, sugary foods. What about calories? And because we have a previous subject who was having normal BMI.
Yes.
And your subject is going to have obesity.
Yes. So
do you feel that the calorie reduction should be there in both groups? Or there should be a difference? You should not do calorie reduction in that?
There has to be a calorie reduction in that, and also the percent carb that comes from calorie. The normal calorie distribution is 60% of carbs should be contributing to your total calories. For an obese person, the person calorie should be around 30 to 40% only. So there's a lot of distribution. So mathematics is involved here.
We have carb counting here. So when a person who wants to reduce weight, he has to do carb counting. Dr. Smita has mentioned about MyFitnessPal, and she has mentioned about Healthify. I use Fat Secret as because I have been able to reduce. I used to count carbs. I used to daily count calories and 1500 calories per day and carbs 50%. You know, it's very difficult to keep carbs at 30-40%. It's impossible to keep carbs with Indian diet at 30-40. Where consuming a vegetarian diet, it is impossible to reach less than 55% of carbs. Practically impossible, and increase to more than 15 grams of 15% of proteins per day. So practically there is a big issue.
I'd just like to add on to my previous comment that when a patient like this comes to you, depending on the history, short-term goal of 3 months where you can put the patient to very low calorie or low calorie diet and then gradually move on. Okay, so this is not a lifelong suggestion. As you said, it's when in your protein talk, it's a dynamic suggestion. So depending on the patient, the suggestions change.
Okay, so what Dr. Vanisha has recommended is the use of low-calorie diet for a short-term time and decrease the amount of carbs to as much feasible or not. So these are the two takeaways things. We'll come on to the next. Sir, madam, please. You have a normal BMI now. And this is the normal. We see a patient who is 60 years old and a weight of only 50 kg and is diabetic. Or 60 kg. So he has a normal BMI.
Okay.
So what do you do in these patients? Would you ask them to change his diet or just prescribe him medicines?
Okay, so what leaps to mind here is we have a case of normal weight obesity, which is a risk factor for cardiometabolic disease. It's a high risk factor for atherosclerosis.
So it's a normal BMI obesity. This
Yeah.
patient has.
But
what
how
you
do you
call this?
how do you label obesity if it's
This
normal?
BMI, I'm
His
talking about
BMI is
BMI.
normal. His BMI is normal, but his fat percentage is more. It's more than 25%
He is
for a
obese
man.
So-
inside.
Inside.
He is fat inside.
Toffee.
Toffee. That's what.
Yeah.
So this group is toffee. He looks to be thin, but he is lots of visceral fat.
Visceral
And this is
fat.
the normal thing we get in India. And why they are more harmful? Less subcutaneous, less place to store the fat, more visceral fat. So they are more dangerous than
Absolutely.
obese people. They are more dangerous.
So basically the fat is the overflow theory. It's not stored subcutaneously, it overflows into the viscera. Now he's loaded with cardiometabolic risk. He has diabetes, he has dyslipidemia,
And
plus
he's
he's normal weight
obviously
obesity.
thin.
Okay, so one of the main things is we are not testing him, that is probably one of the things I'm worried about. You see a skinny guy, you assume he's healthy. So that is point number one. The second is about normal weight. I believe Dr. Sunita already talked, but I would like to mention some specific points. What would I advise to decrease this patient's risk of atherosclerosis? Firstly, the evidence is not strong. Let me start with that disclaimer. One or two things have been tried. They tried two groups with equal number of calories, but one group received a higher percentage of proteins. Interestingly, their weight did not decrease, but the visceral fat decreased. The people who were fed higher protein. Other diets which intuitively make sense in a case like this, normal weight obesity with diabetes, with dyslipidemia, are obviously the DASH diet and definitely the Mediterranean diet, which is loaded with complex carbs, good fats, seafood, less red meat. Now, talk about meat. This is something which probably we should make our patients aware of. What is the difference between animal protein and plant protein? Now, we had a beautiful talk by Dr. Ashish about how important protein is. Why is animal protein dangerous? The thing is, it is metabolized by the gut microbiota. TMA, trimethylamine, is oxidized to TMA, which is half a second more. And that itself is a risk factor for atherosclerosis. So if I have this particular patient, I would probably tell him to focus more on plant rather than animal protein. That's one more thing I do. That's about the veg versus non-veg, and I believe I've covered it. Fasting, intermittent fasting. Somewhere, now I can't quote the paper, but it says intermittent fasting is almost equivalent to the decrease in HbA1c you get from metformin. Imagine.
But I was questioning you whether a patient with normal BMI, would you recommend intermittent fasting?
Yes, yes, because that is 2 or 3 studies which have been
Because
done.
he tends to lose muscle mass.
Not really, not really.
In intermittent fasting, the RDA remains the same. You're only supposed to eat
So
2
why
times.
do you want to decrease his calories?
You are not decreasing the calories.
Just decreasing the fasting content.
Intermittent fasting is just eating at 2 fixed time.
So you want to
whether the
produce
16-8 window.
ketosis in the 12-hour window.
So,
So a 12-hour window is fine,
ketosis.
16-8 window is
Ketosis.
fine.
why does it
Ketosis.
work? So it decreases the prolonged action of insulin. It increases AMPK. It's basically a warrior against atherosclerosis. So
No, I'm taking about very specific question here. Would you require I would myself not advise them fasting. I would advise them on the do more of exercises.
I'm not telling fasting, I'm saying intermittent
No,
fasting.
intermittent
Yeah,
fasting
yeah.
also. So we have people who have comorbidities, who already are thin. It is better to advise them exercises to build up their muscle mass, to convert their fat into muscle, rather than go for fasting, because that becomes a difficult proposition altogether. We won't take into too much discussion on that. Now we have something like last question which we have is this, is a metabolic syndrome with cancers, because here the fasting comes in. Here the fasting comes in. So we have a metabolic syndrome. It's common. The commonest cause of death in a patient with metabolic syndrome is heart disease, and the second commonest is cancer. Okay, so this is so we are already dealing with something heart disease. So what do you do in a metabolic syndrome with cancer? So we have any queries regarding this fasting, because fasting has become more and more important since you have raised that question. That's Dr. Anisha, please. नहीं, आप बताओ ना. हाँ.
In cancer patients, sugar is the first thing that is going to be omitted. Okay. And sarcopenia over a long period of time is another big concern. So giving the right amount of protein is
So sugar is to be omitted in cancer patients?
Definitely yes. Okay.
Do we have questions in the house? We see lots of
But
cancer
at the
patients.
same time, sarcopenia has to be maintained.
Okay.
So the type of carbs that you give, not the simple, the type of carbs, the complex carbs that you give, the protein that you give, the quality of fat that you give, to maintain the total percent calorie is very, very important in cancer patient. Along with that, the foods, functional foods we say, to reduce inflammation, to reduce oxidative stress is essential, and that comes mainly from plant nutrition or probiotics or prebiotics. Thank you.
So anyone of us in the house, so we see cancer patients, do we ask them to reduce, stop sugar? I should frank answers. We should have frank answers. And what is your opinion on fasting in patients with cancer? And we have data on the same or not? So yeah, have you ever seen an oncologist advising to stop sugar? I have not seen an oncologist advising
The
stop
real
sugar.
evidence comes in the PET scan. The PET scan, FDG, is a glucose molecule.
I agree.
Why they use
But
the
why
FDG?
this data is not being implemented by the physicians around? No, this PET scan, I am talking about recent. Recently, if you talk to an oncologist,
That is the strongest evidence
So
that
I
you can
think
ever have
the
that
thing we
sugar
should-
is absolute no in
so
cancer
that is
patients.
one thing. So I think the take home message should be cancer patients should be avoiding
Fruits and fruit
simple
juices
sugars,
as well.
Simple sugars. Not talking about complex. Simple sugars, fruit juices, fructoses.
So fructose is the culprit, and second culprit, table sugar, fructose, and mono and something to add.
That's what I'm telling. Now the
Yes.
first thing is sugar and second is fasting.
Why? Because there is a reason.
Yes. So it promotes. Yes. So I want you to take up that question. What is the importance of fasting in cancer patients? And we don't ask our cancer patients to fast,
No, we have started doing it. Fasting, prolonged fasting causes apoptosis and thereby reduces the progression of cancer.
Cancers.
It also is recommended for people of metabolic syndrome and diabetes are more prone to some of the cancer, which also indirectly intermittent fasting there helps them. Metformin is also acting through CMP kinase also reduces cancer.
So
there
we
are
have-
good number of data which are coming up.
And there are less mitochondria in a cancer cell, so it will not help to digest fatty acid. So beta oxidation of fatty acid will not happen.
The cancers have anaerobic metabolism basically. That's why they are
No,
FDG
even in presence of oxygen, they will still
Well,
undergo
anaerobic in the sense
glycolysis.
ke they have metabolism in the cytoplasm. They don't have
Yes.
poor mitochondria as you told. That's basically cytoplasm metabolism. They have anaerobic metabolism. They have a lot of lactic acid production. That is what causes the angiogenesis. So I think we have finished this session. And if you have last anyone.
Only a very excellent session amongst number of panel experts. Just want like to mention one point I feel that should have been discussed is that this last year only there was a presidential advisory from the American Heart Association regarding this metabolic syndrome. It's part of the CKM syndrome, cardiovascular kidney metabolic syndrome. And any metabolic syndrome, we should be thinking of this CKM syndrome, and there are guidelines now that we should start assessing if the risk factors are more in that individual. We should start assessing the patient right from 2 years of age, and if the risk is less, we should assess the children in the age group is 9 to 11, and next as between 17 and 21. All entire metabolic syndrome comes under now the CKM syndrome, the cardiovascular kidney metabolic syndrome.
I think they should have
In
put
fact,
the liver inside. Because I think it begins in the liver first.
Yes.
And the gastrologist, I am not very
now
happy.
they have
So,
Not very happy with that idea.
So American insurance companies, basically they measure GGT and they predict the future prediction of cardiovascular disease. And then that's how they calculate the amount of premium that should be charged to Americans.
Actually, actually, if you see all the ADA diabetes management charts and everything, they are for CKD, for ASCVD, for heart failure, for hypoglycemia, obesity, but there is no arm for liver. They should have an arm for
Because I think this is the first the liver which gets saturated with the sub-Q phase. As the sub-Q space goes away, it comes the liver. Liver becomes saturated and then starts throwing away fat.
No, liver is the liver part is in the metabolic. If you go to the chart, I have a talk on that in South Indian day after next day. If the metabolic part is entirely on the liver, cardiovascular kidney, the metabolic part,
That is
that's
why-
entirely on the liver.
That's why gastrologist focus on nutrition, because
that's
he
why-
was very much fascinated by this metabolic syndrome and fatty liver, and I thought, okay, it all starts in the liver, and so, and as a gastrologist, I should be the first pioneer of treatment of metabolic syndrome, because that's how I see patients. 20 years, at the age of 20 they have fatty liver, at the age of 30 they have diabetic, at the age of 40 they have heart disease, at the age of 60 they have cancer. So this is how metabolic syndrome progresses.
Yes, and all the guidelines now we are having on the basis of the risk factor. The diabetes guidelines have shifted to the risk factor. The heart failure guidelines also have shifted to the risk
Previously
factor.
we used to believe they
Same
should
for the
be-
stroke.
And I think the role of nutrition is really coming up in a big way.
Yes.
And I request doctors to please hire them.
Yes.
Instead of learning nutrition,
I
we have qualified nutritionists in the house. Please hire them.
One thing that I wanted to raise, UK has CARE-ME renal syndrome association. They have fantastic guidelines for this. Now there is addition of something which is called Carre-Mal syndrome, which is cardio, renal, metabolic, adipocyte, liver, and eye syndrome. So people are thinking in this line, and they are probably day after, I'm going to talk in how to take CARE-ME syndrome disease features into management concept of diabetes management.
So I thank the panelists very much.
But just sorry, if I can just
we
say,
can have that discussion whole day night
Just-
on this.
no,
where
this is
the
just
whole
a 10
conference is on metabolic syndrome.
this is just a 1 second thing that I want to say. We should tell our patients about the 3 evil S. What are they? What are the 3 evil S's? S.
Salt, sugar, saturated
Okay,
fat,
now there are 4 then. Salt, sugar.
saturated fat.
Madam, saturated fat is a big question mark.
Saturated fat is
It's a
not
big question
harmful.
mark. So we both will
In
be
my mind, what I
questioning
wanted
you
to
on
say
saturated
was
fat.
salt, sugar, sitting, smoking. Sitting and smoking.
And
Smoking,
ma'am
I should get up
mentioned,
now.
I would like to clarify one point that she mentioned about animal protein. There is absolutely not a single evidentiary data which includes RCT on animal protein causing cancer. There is not a single RCT.
There is,
No,
there are
it
a
is
lot of
only
paper on
it is
red
only of
meat
processed
and
food.
cancer.
It is only of processed meat.
So I'll share
There
you
is
red
no-
meat and cancer
no-
patients.
And
I think Akash, we have to stop this.
Actually, the meat industry basically uses lot of hormones.
Ha.
Even in US also, they are like a mafia. So the red meats which we eat basically is a tempered red meat, is not actual red meat, and a lot of things are there. And they
So I-
cause-
that is only if
I
you
thank
smoke
the
it.
audience and
That is
thank the
only if you
panelists.
smoke it.
I think
If
we
you
should
don't
have.
smoke it, nitrosamines will not form.
Thank you very much.